Dr. Wern. I'm a surgeon working in Hospital Columbia Rimau, and today we'll be talking on breast cancer. This is to make awareness to the public, and I'll be touching on how these people, the breast cancer people or patients will present with, what are the symptoms, and how we go about examining them and getting the diagnosis, and what are the treatment options available. Firstly, breast cancer is one of the commonest cancer among women in Malaysia, and it starts at the age of 30 and peaks at the age of 50 to 60, and the highest numbers of the patients who present with the breast cancer at 4th to 5th decades of their life. And most of the time in Malaysia, there is no obvious racial predilection between Malay, Chinese and Indian, and most of them, the chances of getting a breast cancer is almost the same. Before that, I would say what are the risk factors for the breast cancer. Risk factors for breast cancer, the younger the age group, the younger they get menarche, and later they get menopause. That means they have the higher period of reproductive age group, the chances of getting a breast cancer is higher. And also people who nulliparents don't marry, or people married and they don't have babies, they have a higher chances of the breast cancer. And also there are some small percentage of the increase of the incidence when they have usage of oral contraceptive, especially oral contraceptive is used before the first pregnancy, and it is more of higher chances of breast cancer as compared to people who have used OCP after the first pregnancy. When we look into that, we know that the higher period of time or more when these people exposed to estrogen level in the body, and the chances of getting a breast cancer is higher. At the same time, breastfeeding reduces the chances of breast cancer. It is protective against breast cancer. And many babies also is another protective against the breast cancer. That is one of the commonest risk factors. Obesity, especially in the women who are obese, they have a high chances of breast cancer as well. Very sedentary lifestyle, lack of exercise also contributing to breast cancer. Most importantly, another aspect we need to consider is whether the family has got a background history of breast cancer, ovarian cancer or colonic cancer, and genetically they are much more having high chances of getting a breast cancer. When we talk about genetic, they have genetic coding known as BRCA, breast cancer antigen 1 and 2. When they have this antigen within them, the chances of breast cancer also increases tremendously. The clinical presentation. These are the risk factors for breast cancer, and how anybody will come to medical attention when they have some symptoms. Most of the time they have some kind of a lump. That's the very first thing. Mostly painless. In initial stages it is very not much of pain, it's only they feel the lump. Or sometimes they can have a nipple discharge, especially the bloody nipple discharge. It is a bit more sinister as compared to either pus discharge or some whitish discharge. And also they can say that the skin texture of the breast is changed, little edematous and also small dimpling, what we can see, what we call the purely orange appearance. when I have that, that is basically because the tumor infiltration into the lymphatic drainage, causing that lymph edema over the skin, causing this orange skin-like appearance, what we call the purity orange appearance, and also ulceration. If any ulceration and it's not really healing over the breast, then we need to think about that. And the other thing is nipple retraction or cracking of that areolar tissue around that area also need to be careful and need to come to medical attention as soon as possible. And also sometimes what they can feel that it is asymmetry, and all the while it's a symmetrical breast, and suddenly they can feel right breast or the left breast it is slightly different contour, or it is very firmly adherent to the, it's not really as mobile as used to be previously. So these are the changes normally bring this women to a medical attention. And normally we tell the patient that any abnormality you don't see from the beginning and suddenly you start seeing something different, you have to come for medical attention and need to get an expert opinion, need to investigate it properly, and we can do follow up with that. And most of the time the breast cancer in the early stages, they don't have any pain. They are pain-free, and only they could feel is lump. So when they come as a medical doctor, we examine them, then let's say we find there's a nodule, well, then we have to go for triple assessment. In the process of diagnosis, the triple assessment is very important. Why we call triple assessment is because triple assessment constitutes clinical examination, ultrasound in order to get the right diagnosis, or mammogram in order to get the right diagnosis. Then finally we must have a tissue diagnosis in order to say that whether we are dealing with breast cancer or something else. And we know that most of the time the lump in the breast, painless lump in the breast, it is always at the age of 30 with the risk factors always pointing towards a breast cancer. Not always, but mostly is pointing. When medical doctor examine, then we'll put all the factors together with the symptoms, with ultrasound findings. Then we have to investigate to rule out whether we are dealing with a breast cancer or not. So fine needle aspiration is utmost important in order to diagnose breast cancer. So we do ultrasound if, let's say, the patient is less than 35, because the breast density is a bit more denser, and mammogram won't be very ideal in this kind of group of people. So normally we ask for ultrasound. Ultrasound can differentiate between nodularity, nodule, lump, between normal architecture or abnormal architecture of the breast. If, let's say, these people are more than 35, then we advocate them to go for mammogram. Once your mammogram is done, ultrasound is done, if the mass is palpable, and we ask the radiologist or the surgeon or the attending physician to do FNAC in order to get the tissue for cytological examination. And we send these slides to the pathologist to report. The cytologists, they stain the slides and they report to us that whether we are dealing with cancer or not. And most of the breast cancer, in pathologically, what we call is the adenocarcinoma of the breast. So once the report comes back as adenocarcinoma of the breast, then we have to tell the patient what is the next plan. In order to say that what is the next plan for that particular patient, we need to stage the disease, right? Because each and every stage of the disease, the treatment plan is different. Okay? Normally in clinical situation, we normally use clinical staging of T&M classification. T stands for tumor, N for nodule, and M for metastasis. And for T classification, if, let's say, the tumor is less than 2 centimeters, considered as a T1, between 2 to 5 considered as T2, anything more than 5 considered as a T3. If, let's say, any tumor size but it is already fixed to the posterior chest wall, it is considered as a D4 lesion. It can be 1 centimeter, it can be 10 centimeter, as long as it is actually fixed to the chest wall, it's considered D4 lesion, or any ulceration or any satellite nodule in the skin, or another entity known as inflammatory breast cancer, any inflammation, but that inflammation is not because of any infection, but because of the tumor, is really classified as a D4 tumor. N1 and N2, it is considered how much of the lymph node is actually gone to the axillary site. And also M is metastasis. The tumor has gone into other places other than the breast tissue alone, especially to the liver, to the lung, to the brain, to the bone. So depending on what stage we are dealing, we advocate the patient to go for subsequent treatment. And most of the time the treatment involves, because the breast cancer, we know that it's not only a localized disease, it is also a systemic disease. So we need to subject the patient to go for local treatment, after that systemic treatment, again depending on that, what is the stage we are talking about. Mostly the surgery, either we remove only the nodule, or we call wide excision, or we call segmentectomy or quadrantectomy, where this wide excision, quadrantectomy and segmentectomy constitute breast concealing surgery. That means we are not removing the whole breast, only the part of the breast is actually removed. We are preserving the breast. If let's say the tissue come back later as breast cancer, we ask the patient to go for radiotherapy to ablate the rest of the tissues. Or if let's say the tumor is big and we ask the patient to go for operation first, what we call is modified radical mastectomy plus chemotherapy in certain, what we call the adjuvant chemotherapy, because as I mentioned earlier, it is not only local disease, it is also systemic therapy. So we have to ask the patient to go for chemotherapy in order to kill off the rest of the tumor. Elsewhere, if let's say the tissue has gone somewhere and hovering there, we need to kill off those tissues, those cells. If let's say the tumor is quite advanced and we can't operate, then we need to give some form of a chemotherapy in order to reduce the size, then subject the patient to go for surgery. What we call is neoadjuvant chemotherapy. We give a chemo first, then subject the patient to go for operation later or radiation later. So these are the treatment options available, and now we have other options. A lot of newer drugs are coming in, and traditionally what we used to use is tamoxifen. We prophylactically put the patient on tamoxifen, and with the chances of recurrence and the tumor coming back, it will become much lesser. And now we have a latest drug which is known as aromatase inhibitors, and also we can put the patient on those kind of a chemotherapy. That's depending on what kind of a tissue that report, histopathological report comes, like whether the pathological tissue of breast cancers got the higher of prostate receptors, ER or PR, estrogen receptors or progesterone receptors are positive. Depending on that, we modify the medication we're supposed to carry on after that. Those are the treatment options available. Most importantly, before that, because this is community-based and we wanted to make the public to aware of the breast cancer, what we normally emphasize is prevention is better than cure. So people who has got the high risk, especially the first degree families, especially the mother or daughter, those are considered as the first degree. Second degree is a granddaughter or grandmother, they are considered as a second degree. The family has got the first degree breast cancer, and the patient themselves are contracting this disease, or the chances of getting the disease is much higher. Those kind of people, they need to go for screening much earlier. Normally we the screening roughly starts at the age of 35 to 40. So these people probably would advocate to start at least about 5 years earlier than that. So how we do screen with a mammogram or with the ultrasound, and we have found out that by doing the screening and the chances of detecting early cancers, the very small cancer, is that the chances of detecting them and treating them earlier definitely prolongs the survival. Instead of wait until clinically apparent tumor, then you come for medical attention. Obviously, the bigger the tumor, the bigger the operation, the higher the chances of recurrence, the higher the chances of tumor deposited to elsewhere, the higher the chances are. So our main aim doing a screening is we try to catch them much earlier stage, then we are catching them much later stage. And we actually have got a study to show that catching them much earlier through the screening process and catching them later when clinically apparent tumor, the survival benefit is obviously much better for the people who come for the screening. So who are the people who actually come for screening? People who have got the first degree and second degree family members who have got the higher cancers, breast cancers or ovarian cancers. People who actually have got a history of exposure to radiation or radiation, especially people who are working in radiology department who frequently exposed to radiation. So those people got a higher chances of tumor coming there. And people who working in a very nuclear reactor, especially the chances of tumors coming there. So those people are actually got a higher risk of a tumor coming. So they have to go for the screening. But general population, I think anybody more than 40 years old, I think probably 2 to 3 years once, I think it's worthwhile to get the screening in order to detect a much earlier.